Hello, everyone, and welcome back to the Behavioral Health Eco Series training program brought to you by the Center for Substance Use Training and Telementoring CSTAT, a division of the Be Well Institute here at UT Health San Antonio. My name is Andrea, and I will be helping to facilitate this conversation today. Before we start, I want to remind you, as always, this session is being recorded for later distribution, and it will be available to all of you at our Be Well Texas YouTube page. To help us with attendance, please continue adding your names, email addresses, and affiliations on the chat. We will need this information to confirm your attendance, but also if you are seeking CEUs today, please make sure that you identify yourselves. If you're joining via phone, you may also send an email at cstat@utesca.edu so we can associate your phone numbers with your names. And in today's session, we're going to have Dr. Denis Antoine presenting for us. Then, as usual, we're going to open the room for your questions. And then Leslie Manson is going to be discussing a case. And this is the part of the session where we invite all of you to participate. Please raise your hands and ask questions, give your takes, your opinions. Remember, the echo space is the space of all teach, all learn. So in this space, we're all experts and we're all learning. So everything is fair game. So please take part in the conversation. And we're going to start with some introductions from the Behavioral Health Hub. Elisa, welcome to Behavioral Health. How are you today?
Hello, I'm doing well. I hope you guys are doing well as well. My name is Elisa Medellin, and I am with UT Health Strong Star. I work primarily with veterans that are dealing with PTSD. And so I'm a consultant as well as a study therapist there. I'm happy to be here.
Welcome, Elisa. Dr. Antoine,
Hello, everyone. Denis Antoine coming from Baltimore today, an hour or so ahead or behind. I forget which direction sometimes, but a psychiatrist by training and working within two clinics that primarily serve individuals that are underserved with substance use disorders. Looking forward to the discussion and all the feedback today on this talk and this topic.
thank you. Leslie,
Hi, everybody. I'm Leslie Manson. I'm traveling today in case I cut out, just to let everybody know. But I'm coming to you from Phoenix, Arizona. And actually, I am a director of implementation science and training. I have clinical experience for over 20 years, providing direct care, consultation, training, education, and interventions in behavioral medicine. So within primary medical settings. So thank you.
welcome, Leslie, and Dee Dee.
And good morning. I'm on the other way from Dennis, from Emeryville, California, where I have a private practice where I see individuals, couples, and mainly families these days, working with folks that are concerned around their substance use. So what I do is help people to examine their relationship to substances. I've been doing this for nearly 40 years now. I'm also associate professor at St. Mary's College and do a great deal of training, mainly in motivational interviewing, but also in solution focus and a few other client-centered, what we used to call evidence-based practices. Don't know what the term is anymore, but that's it. And harm reduction. Thanks.
Thank you. Thank you so much, Dee Dee. So I think we can start sharing the PowerPoint didactics. And Dennis, Dr. Antoine, whenever you're ready, please take it away.
All right, thanks so much. And as the slides say, my goal today is to talk about addressing substance use in older adults. And as you'll see, I'll not only talk about strategies for engagement and support, but really try to focus on what is the overall picture of what this issue encompasses. And I think it'll take us in a lot of different directions as we get into the case and the discussion. But my goal is to really look at this, I would say, growing and sometimes under-recognized population. Thinking about the beginning, standard slides about disclosures, no relevant financial relationships to disclose here. And these are of my own opinion here, not of UT San Antonio or Johns Hopkins where I work, but just given the standard slides there. And as I mentioned, I have overall objectives to look at the unique challenges and risk factors related to this population, and identify strategies that effectively engage older adults in conversations about substance use within behavioral health settings. And I'll also talk about primary care settings as well. And then talk briefly about evidence-based interventions and community resources tailored to the needs of older adults. I think this is one where we'll see it's an objective, but there's a lot of room for growth there, as Dr. Manson will probably point to as well in her expertise. So I start out with just defining what is aging, what is older, and that has a lot of different definitions. This is a list of them, but not a comprehensive list to start out. It's not a great clear definition at this time. The UN says 60 or older, WHO, World Health Organization, says 65 or older. And then we have things related to Social Security benefits. And if you look way back in Britain, in 1875, the Friendly Societies Act defined it as greater than 50. So where do you start? It's not always clear, but it is very clear that people are advancing in age all the time, and we need to think about what happens when that advancement comes. Another way of looking at it is that it's not just about baby boomers. At least in the United States, it's I always see these things about baby boomers versus millennials or Generation X or whatever it may be. And I'm actually a zennial. I don't always say where I am in the whole thing, but I'm a tweener. So I'm a part Generation X, part millennial. And Generation X is looking at this from a different perspective, where it's had to deal with multiple pandemics and epidemics, the crack, prescription pill, ongoing opioid epidemic. So across the continuum, you have a generation that is now getting towards this quote unquote aging population. And that group will be squarely into Medicaid in the next 10 to 15 years, including myself. It's very interesting to think about. And so that is part of this projection that was put out there back in 2012, saying that in 2030, we'll have 72 million individuals that will be Medicare eligible. And that's a staggering number, considering that it was shown that in 2010, we were looking at 40 million. So that growth is big and driven more so by Generation X rather than the baby boomers, who probably bared an undue brunt of the responsibility, at least in the media at this time. I saw that handy. So we have to think that through as to who we're talking to and make sure our message is tailored in the right way for that. And why is it important to think about aging populations overall is multifactorial as well. There are different things physiologically, and I won't go into this in detail, but there are changes in the body that happen, whether it's how the body breaks down the drug, how other health problems can compound with ongoing substance issues. We have to think about the complexity of all these things acting on the body and how it might slow down the breakdown of medication so they're more potent than they should be. And whether you're talking about illicit substances or prescribed substances, there are things that might be unintentionally used at a higher dose. For instance, there's more and more literature showing that gabapentin is being used and misused in the population, and that for a while was being prescribed everywhere for anxiety, for pain. But now we're getting to a point where if the body does slow down, or if there are 7 other medications in the mix, gabapentin may not be the safest thing. So interactions are very important to think about, not just about substance use disorders, but just about what happens when you have this mix of all these different things, and that's really important. And cognitive impairment, whether that's an adverse effect or baseline issue, is something that needs to be thought about. All potentially leading to increased risk of falls, confusion, delirium, all these things below, which have nothing to do with substance use disorders on their own, but could be something that could be tipped over by a substance use that is undirected. So that's why it is a big thing to keep in the forefront of our minds. Psychologically, something else to keep in mind, and I was a psychology major, so I usually try to bring these things to the forefront, are Erickson's stages of life. And that, crudely is basically saying that at different stages, there are different tasks or milestones that a person has to resolve to healthily progress psychologically. Putting it at the range of the quote unquote aging population, the two big stages are generation versus stagnation, whether a person's going to be active with their life or stagnate at a certain point, or when they get to the latter phase, would be integrity versus despair. What will they be able to hold on to, hopefully through wisdom, And otherwise, there would be despair looking back at the other stages of their life. And one would say psychologically, if people are not able to successfully get past these stages, either with care through the generation stage or with wisdom in integrity and despair, there are going to be psychological setbacks that also need to be thought about. And how do you deal with those? So I put that out there just to say that sometimes there are transitions that occur, and if they're not done in a smooth fashion, they can be problematic for a person. Now, I think society's looked at it differently when it comes to substance use. And I put this out there to say back in 2011, when we were at 40 million, roughly, this is how society was talking about substance use in aging populations. I don't think it's the right words that we would think of right now, but all to say this is where we were. Oddly enough, and my computer's advancing on its own here, so sorry about that. If you were to look around the screen, you would see some other things that were interesting at the time. One of them at the bottom says if you want hospital admission, you have to pass a drug test first. Another says maybe we should think about integrating care of hepatitis C and other types of behavioral health treatment. All things that we think about now that are straightforward. But back then, including invisible addicts, these were things that people felt safe and say. And I think things have changed since then, fortunately. You fast forward to 2017, and actually a little bit before that, the SAMHSA report came out, the Treatment Improvement Protocol for Substance Abuse amongst older adults. Again, still terminology is not clear, not exact, but at least we're going in the right direction. And I think that is a good sign as well. Moving forward a little bit more, SAMHSA did a little bit more in this work and finally saying maybe we should think about a day in the life of older adults and what does substance use look like in that case. And I would encourage folks to go back and read these reports just to see what the nuggets are there and also look at the gaps that were there. But most important, I would say, of this report, it did say to look at the whole day, truly, of what's going on in that person's life. Where are they staying? Who are they around? What is the environment that's going on? And substances can be part of that, alcohol being the more common one. But it's important to understand the environment. I would say the people, places, and things, and other people might say the antecedents that could lead to substance use in these older populations, because often the social environment can play a big role. Some of the problematic things, just to get into the details, might not show up the same way as a person who is in the younger stages, maybe not the teens or the 20s and 30s, 40s, but there are things to keep in mind. And this is one of the few slides where I'll say, look out for these things. And psychiatrically, you might see certain changes that might look like mood or sleep disturbances or irritability. But there could also be coordination difficulties and tremors on the physical side. The classic case that I was always given is a person goes in for a surgical procedure and they have to stay for 3 days, and all of a sudden on day 2 or day 3 they start shaking. And that's typically something that might show up to say, well, they're away from that environment where they were able to sustain, whether it was the alcohol or other things, and it was uncovered that they're having some type of withdrawal. Other physical signs, injuries, bruises, malnutrition, some of which are also in other age ranges. But I would say things like confusion and disorientation, aging populations are a bit more sensitive to, given, as I mentioned before, there are already age-related changes that are occurring. So these are things to keep an eye out for, not all specific to older adults, but things that could come to mind. Now, the National Institute of Aging also put out their own thoughts about what to do in these changes of life, as they said. And this is their list. I don't think it's comprehensive at all, but it's a start to the process to say, one, thinking about major changes in life. They put down retirement as being a big one, moving away from your home of many years, and also changes in social support. But I would also put out there that this is a time where there could be changes in the network itself, where there are a loss of individuals, loved ones, spouses, friends. Those are changes in social support that really need to be prepared for because they might not always be anticipated. Retirement, at least you can, for the most part, pick when. Moving as well, but that's a big change that could make a difference there for sure. And making sure there's ongoing social support with family and or friends. Individuals who've had long periods of time with substance use disorder may not always have the family that one would want to reach out to. In our clinic, we call individuals maybe community support because it may be a touchy point to have a family that you're disconnected from. And that's something to keep in mind. So that would be a revision I would make to this National Institute of Aging advice. Regular exercise, also something to think about, but if there are physical limitations, you'd have to figure out what other activity might be good and how to account for that and maybe have modifications. And then picking something you can like to do was their recommendation, but also that you have access to. In this day and age, the digital divide and really takes away access to things that are online. And if there isn't the transportation or other social determinants of health barriers, those need to be put in place to make sure that you not just pick it, but you can do it on a regular basis so it's there. And then the same goes for balanced diet. Depending on where a person is, they may be in a food desert or other places. So that access, I think, is important alongside of what they should do, making sure that they can do it. And I think this is another type of list that will likely need to be updated in the years to come to make sure that it is in line with what persons can do. Now, I put this up here not for people to read this whole slide, but this is actually a study I'll be publishing in the next 3 to 4 weeks. We're finalizing the submission now, but all to say this slide shows a review of a systematic review that I did with a few colleagues, and we tried to find newer interventions for individuals that are aging. And it showed that we looked through 580 articles that we found through a wide search to say, do you have new clinical trials or interventions that might guide us to do new things in this population? Because we can always take something off the shelf and say, let's do CBT and just give it to aging persons, and that's where it is. But what we found, to cut to the chase, is out of 580 articles coming to the bottom, we only found 12 within the past 10 years that gave us something new. And those 12 articles essentially told us to say we can try to tailor and make CBT or other things age specific, but outcomes still were the same. The outcome was always abstinence or drug free. It wasn't about how did the person feel. It wasn't about whether they felt more alive or felt more valued or felt more connected. It was about the drug itself. And so this is really something that was striking to me to say there needs to be more work done, not just to tailor the existing interventions, but to create something new for this population in particular, so that we know that they're getting better and feeling better and probably having less motivation and drive to use that substance, which may be giving them that feeling. So if you see anything out of this, it's out of 580, there were only 12 things, and there wasn't much in there. Now, a couple of things, and I'm keeping track of time as I talk these through, is we also need to think of new locations. There's nothing wrong with the therapies that we have, but sometimes it's about where we put them that can make a big difference. Online may not always be the best place because people don't have access. And I can tell you that's not an age-dependent thing, but it's something to think about as to where these interventions are put. I would say there's more emphasis now being placed on primary care locations because oftentimes, as I mentioned before, that's where the bruises or the falls or the coordination or the confusion may come up first. And it's important that primary care practitioners know how to look for those and find the best screenings for those. It could be an audit C, which is a screener that is used commonly, or it could be just asking the question, are you doing anything different in your routine over the course of the day? Vaping, smoking, drinking, whatever it may be, just asking the question can be helpful in the primary care setting. And I think primary care doctors would need to know who to reach out to. And that's always a difficult step because the goal is not for them to do all of the care, but to know who to reach out to. We have a connection here at the Bayview campus in Baltimore where we have something called Elder Plus, where individuals are identified there, but then sent out to different behavioral health practitioners. And some behavioral practitioners come to the primary Elder Plus setting themselves and meet with the individuals there each week. So that type of integrated care could be a way to cover this, especially since Medicare doesn't cover all behavioral health treatment at this time. I would also put out there, places where people go to religiously, and I say that in multiple ways. Barbershops and salons could be one because people go there regularly, and that's a place of community and connection that could be taken advantage of in many different ways. And also faith communities, whether a person is, of that faith or not, just understanding what's socially viable and important to them. Going back to Jerome Frank's portions of his psychology thinking, what's important to that person to make sure that we know where they are. And I put a kind of a snapshot of what myself and one of my colleagues is doing in congregational settings across different religions right now to try to engage people to learn more about what depression and substance use looks like just in different places. And we've been able to go up and down the Eastern Seaboard already. And I can imagine primary care doctors doing the same or barbers doing the same just to say, hey, let's talk about it and make it more of a normal conversation. So persons who are aging would feel more comfortable saying, yeah, well, that does relate to me. Where can I get more information? And so that type of approach in terms of the location, I think, is where we're going next because the doctors may not always be able to pick it up. And I do think that the social setting makes a big difference in terms of how that person can maintain connection. So, without going over everything, I would say, we are at the beginning of this new epidemic, if you will. It's not just the baby boomers that are driving it, but aging populations will get larger, as I said, almost to 70 million, and we need to get ahead of that. Life changes play a role with it for sure, because there are many life changes, but we also need to think through what's happening in terms of the growing prevalence and the underappreciated interconnection of the medical, the psychiatric, the social aspects, and where do we find support for these individuals in the different settings that we may already be using, but we may not be using. And so that's an opportunity to think that through more. I think our case today will show that a little bit because it's not just about the medications, but it's about opportunities to think through how can we do things differently to get this person moving forward. So I'll stop there. I'll take questions and thank you.
Thank you, Dr. Antoine. And now I'd like to hear questions and input from our group. And it's interesting, Dr. Antoine, how you show there how the language has started to evolve at some point. Like some of those things, we wouldn't say them right now. And it's possible what will be happening in the future that some of the terms of the words that we're using, we probably might not be using it later on. We'll see.
It's important to think about. There's already a shame associated with individuals who go through substance use and other behavioral health issues. Compound that with a person who might be isolated socially. You want to create an environment where they're comfortable to talk about it. It's comfortable to talk about, well, yeah, maybe the drinking got too far ahead of what I was thinking, or maybe I would intend instead of one gabapentin, I ended up using three, and you want to leave room for that. So I think you're right that the language needs to be thought of carefully so we can just say, okay, let's make sure you're in a safe use pattern or something. I'm making up terms here. But maximizing the comfort will be really important. We already have an issue in the field where individuals, and that's why I was a little bit late stumbling in, individuals may feel uncomfortable talking to other practitioners about their issue because they weren't brought in the right way. So that language is going to be really important.
And I think, Holly, would you like to unmute, please, and ask your question?
Sure. So Dr. Antoine, do you know of any substance use programs like in practice right now that are specifically tailored to older adults that we can use kind of as a landmark?
That's a great question. The short answer is no, unless other experts on the call, Hub or not, know of this. But I would say that there are primary care programs that are looking closer at behavioral health screening. And the Elder Plus program at Bayview is what I would hold out there as one, Johns Hopkins Elder Plus, because they look at it from a multi-discipline approach. They have a social worker involved, they have transportation, they do have a psychiatrist that comes on site every week to meet with the individuals, and we're about 3 floors above them. So while my clinic, the substance use disorder treatment program, is not treating that group primarily, we're a close partner with them. And I think that type of model is where people will be going to partner on this because Medicare does not cover substance use disorder treatment fully right now. it
Mm.
just turned around the billing for that about a year and a half ago. So the programs haven't really wrapped their head around that to become expert in it, as you're asking. So I predict that you will have partnerships between strong multidisciplinary primary care offices and substance use disorder treatment professionals in order to do that. But this is a wide open field. That is why my slides are so barren, frankly, because there needs to be more work in this space.
Thank you.
Other questions from the group? And it's interesting to me also, Dr. Antoine, that it seems that there is not really even a consensus on what older adult means. Like, because I know that we all have sense that the concept of age has evolved and changed with time. Like in the old times, person who was 50s was considered old, and nowadays that has evolved and changed. But it looks like also in science, there's no such thing as a specific age.
I would fully agree. And in the past, I think we associated age with roles, but as Dr. Manson pointed out, if there's a grandparent taking care of three grandchildren, that kind of really flies in the face of that. So defining the age is important. I also think not defining, but just characterizing the roles that that person plays is very important so that you can tailor the intervention around that. Because if you have a grandparent taking care of three grandchildren, you're not having them come in to a clinic 3 times a week. That's going to be very difficult. So that type of tailoring, I think, it really is wide open. How do you do it? How do you make sure what's going on? And Dee Dee, thank you for that resource. You're educating me. And so I'm really the reason I put this article together is to try to build this type of programming. And so I might even reach out to Betty Ford and see what's going on there. Not an advertisement for them. Um, I would also say that we
Why
need to
not?
make resources that are affordable for everyone because I do know Betty Ford is not accessible for everybody. So um, huge opportunity here. Please reach out to me if anyone knows anything else. I see you, Dee Dee.
Yeah, one of the things that you just brought up, the financial piece, my understanding is that Medicare will cover some substance use treatment, but not necessarily residential treatment. And not that, I mean, most people don't need residential, but some people I think particularly, and we're talking about my age group, and older or younger actually, could use some of that, even if it's just a break. So I often counsel my own clients that when you're looking at should I do outpatient or residential, it's about what kind of support do you have and do you need a break from this habitual risky behavior that you're engaged in? And if not, then sure, an outpatient would be great. And if you do, if you feel like that could be kind of a break for you in a breath, then that might be a good option. The other thing is my concern just generally with treatment, and we all know this, is that almost all of it is abstinence only focused. And at my age, you know what? If I want to have a drink, by gosh, I'm going to have a drink. And that's it. Now, I don't happen to drink, but who knows what'll happen in my future? But I think that that's something that's reasonable to think about. I had a good friend who lived to be about 104, and I used to make her old fashions. Her doctor didn't want her drinking, which she was in perfect health. She had money, so she had people that could come in and help her. She lived alone. I went in and I would make her a very short shot, old fashioned, and that would be her one drink. And I said, of course you can have a drink. You're 90 whatever she was years old at that point. So I think that is another piece that we're going to have to balance in this culture.
I fully agree. And what is covered through the insurance to piggyback, I've been trying to do this over the past year, is heavily weighted off of only certain types of practitioners. MDs, PhDs have to start the treatment. It's not necessarily driven by peers or other individuals that could really be helpful. So a lot of nuances that need to be built out there. I don't want to take David's or others person's spotlight there.
David,
Yeah, thank you, Dr. Antoine. It was a very interesting presentation, particularly relevant to me. I'm 73 years old. Uh, I've been in recovery for 13 years now. I'm in an abstinence-only, program. And so when I had knee surgery recently, I knew I had to be very careful with the oxycodone and so on. What I was only dimly aware that I should be also be careful with the gabapentin, but I am dimly aware of that, and now I'm more keenly aware of it. I will not, the label says take one or two every night at bedtime. I will not take three, and I will not take them 2 nights in a row. So I appreciate everything you shared with us.
Not a problem. And I think moderation is key for everything, including those things. It's not to say don't use them at all, but make sure you're talking about the risks and the discontinuation strategy. That's how we got partially into the opioid epidemic, partially, because people were just given stuff and said, hey, you can just stop whenever you want. There is a withdrawal profile for gabapentin, and people don't talk about that and the risks of high doses. So continual conversations with the prescribers on strategies for discontinuation is key.
And now that you mentioned that, Dr. Antoine, probably a good topic for a future echo in this same series, to talk a little bit more about discontinuation and gabapentin and that kind of things. That it seems to be related to clearly to substance use disorder. So we may talk about that later.
Sounds right to me.
Yeah. Well, I think in the interest of time, we're going to move to some quick announcements and then to the case presentation. But of course, today the didactic presentation and the case are so together that I know we'll come back to some of the topics or some of the aspects of the didactics and the case together later. So, Taylor, if I can see the announcements, please. Thank you. And to claim CEU credits for today's session, just make sure that you answer the survey. We're sharing the survey link with you all on the chat, but we'll also send it always in an email along with the materials after the class. Make sure, please, that you answer that survey and that you answer yes to the question related to CEUs. And remember that answering the surveys is not just about the CEUs. It is very important for us as a team to know what are the topics of areas of interest or trainings that you need. Please answer the surveys because those surveys inform this series, and we want to tailor all our topics and sessions to you, our learners. It only takes 1 minute. Thank you for answering the survey. Next. And we're always looking for case presenters. If you want to present a case with us, just send us an email at cstat@utesca.edu. We make it really easy for you. We'll give you a short, easy to complete form, and that's it. This case presentations add incredible value to this session. So please contact us and we'll make it easy for you. Present a case with us. Next. And the Center for Substance Use Training and Telementoring, CSTAT, continues to offer technical assistance on a variety of substance use disorders needs. If you need technical assistance from us, just go to the website we're sharing on the chat, and there is a form there, and someone will get back to you in approximately 2 days. Please remember, it's a great service. It's free and available to all of you in the community. Next. And of course, this is great news. March 2 and 3, again, we're having the Texas Substance Use Symposium here in San Antonio at the Henry B. Gonzalez Convention Center. We're so excited about this. We have great thing in store for you guys. You have no idea all the great speakers and classes that we are putting together for you all this day. That's March 2 and 3. Please save the date here in San Antonio at the Henry B. Gonzalez Convention Center. Next. And next month, on October 31st, we'll see you again here at the Behavioral Health Echo. Remember, all these behavioral health echoes happen on the last Friday of the month. And I think now we can start sharing the case. And Leslie, we're going to let you um, describe briefly this case, some of the main challenges, and then we'll take it from there. Thank you.
Thank you. I think the case is just being pulled up. Okay, wonderful. I'll just go ahead and walk through the case so folks don't necessarily have to enlarge it to read it at all either. So this case is about an individual, female. She is Caucasian. She's approximately 73 years old. She is currently residing in a care home facility, and she recently had moved out of her daughter's home. Now, the reason this case come up because the primary care provider who is currently treating this individual had requested for just general recommendations from this echo. Recommendations it could be for this patient, for her care. Maybe it's recommendations that she can give to the nursing home. Maybe it's recommendations that she can provide to the daughter or other family. But just to kind of give you a little bit of context here. This woman, again, is in a care home. This care home, she's been living in for just a short amount of time, for about 2.5 months now. Prior to that, she was living in the daughter's home. And due to the fact that she needs more and more care, and due to her ongoing alcohol use, the daughter did not feel that she was safe continuing to be in her home. So then she was moved into the care home. While she was in the care home, she was continuing to drink. She drinks about one bottle of wine per day, and sometimes she'll drink a little bit more, but no one really has a full grasp on that. During the time she was in the care home, she started to escape the care home, literally, kind of sneaking out, breaking rules, sneaking through windows even. She is a extreme fall risk. She has some very concerning medical conditions. So she's had pulmonary embolisms before, which are blood clots. And for standard treatment, it would be blood thinners. Due to these behaviors, her fall risk, and the fact that she continues drinking, her care team decided to take her off of those blood thinners. She's also had several motor vehicle accidents. She's had MRIs that have shown chronic small blood vessel disease in the brain. This often has multiple, kind of presentations, some of which could be some cognitive decline that's been happening. This is also a woman that has not graduated high school. She had predominantly worked various jobs throughout her lifetime. So she was more actually taken care of by her daughter throughout her lifetime. There is suspicion that this individual has significantly lower IQ and developmental presentation. So just to put that on to this as well. They do believe her judgment is on a regular basis impaired, and that she does not have legal ability to make all of her own decisions. So just to note that as well. So she was, as I said before, escaping out of the care home. The care home basically put a stop on it and said, okay, either A, you have her come back into this care home and you bring her alcohol here because we do not provide it. You bring her alcohol because she cannot continue to kind of escape the way she's doing this. And if you do that, then she can stay here. If you do not do that and she continues to escape because she wants to obtain the alcohol, then you're going to have to remove her. She's going to have to return living with you. So in short, she is remaining in the care home. In this care home, they are right now bringing her alcohol and giving it to her. So the daughter said that she's buying, bottles of wine and just basically leaving that there for her. But the question came up is, what are other recommendations? Just to be very clear, this person does not want to quit. What she would like to do with the rest of her life is to drink alcohol and be there. And that is it. So she does not often engage in other types of health behaviors, although she can be somewhat social with others. That is the extent of what we know about her and what we know of the case. There is some information kind of below. She has not been on any other medications or treatment than what is noted. And she does have some other things like high blood pressure, high cholesterol, those types of other conditions. So just to kind of note that. So just wanted to open up to see what people might have for recommendations for this primary care provider. I know that we might have a few that might be coming up for folks. And I also want people to really consider what are those recommendations, maybe even for the care home or for the daughter as well. And again, as you see, there has been no known history of any services or substance use services ever in the past. Daughter's never reported any, and she's never reported any. And on any of the screening tools, there was no evidence related to trauma history for her. There is high alcohol use, and that has been throughout her lifetime in the system. As far as her thinking, that continues to have significant cognitive delays and some significant patterns of continual, kind of unfortunately, lowering related to that as well. So in the past few months. So just want to open it up. What are folks thinking? What type of recommendations might you see or have for this primary care provider? Something that they can do.
I'll jump in first because I know there will be more thoughts. Primary care, I know Dr. Luebner is probably going to add on to this. In his practice, just making sure all the things are where they should be with some of the vitamins. I saw thiamine in there, but do they have a deficiency? Do they have other metabolic deficiencies that could be helped along the way just to maintain the person's cognitive and medical status? And I think Dee may brought it up earlier. What is the goal for this individual? What do they want specifically? So that we're not imposing our own thoughts on them. 73, what role does it serve in their life? What do they want out of their day? And are they getting that alongside the alcohol? So I'd be curious what type of programming activity they have in that place where she's staying as well. And, are there other things to do? Because this might be filling a void. But those are my initial thoughts. Not even sure about medications, even though there are possibilities there, but I'll hear out others.
Dr. Liebner.
So, clearly her life goals are not compatible with this nursing home and what the family wants to do. So they're, right off the bat, the primary care provider needs to sort of perhaps facilitate a negotiation between her and her family and the nursing home as to what could be done. In terms of decision-making capacity, this and also, whether she can make her own medical decisions. Generally, what I've seen is we don't impose our will on people any more than absolutely necessary to keep them safe. So I think that, from a safety standpoint, that's something that I just don't know how much this PCP is going to want to do. A lot of times nursing homes have basically physicians that come through there and see the patients and that deal with this. So if this physician is seeing his own patients in a nursing home, then he would be a good candidate to essentially negotiate what is the next step, because whatever's going on is not working. So that's number one. And then, so just to summarize that, nursing homes have to balance autonomy with duty to protect. If the resident has decision-making capacity, they technically can make poor health choices. If the capacity is impaired, a surrogate decision maker, guardian may need to be involved. And then obviously we want to document all this pretty thoroughly. So, people who want to help, they know what's going on. So the other thing is environmental controls. I don't know what kind of facilities is exactly and how easy it is to sneak out of there, but I don't usually see people sneaking out of nursing homes. It seems to be, I think it's very difficult. So maybe they can improve their um, their environmental controls and supervision. Maybe she needs to have a sitter some of the time, at least when she's awake. Also, clearly, she seems pre-contemplative in terms of alcohol. She's perfectly fine with her alcohol use, but the nursing home and family are not fine with what's going on. So it's going to be really hard to engage in some type of addiction treatment with somebody who doesn't want to quit. I think the other question is, does she have does she have dementia? Has a mini mental status exam been done? Have PHQ-9, GD7s, or some kind of psychologist or psychiatrist evaluation of this patient in terms of what else is going on here? Is she able to remember enough information to make decisions? And then there could be some kind of ethics consults depending on what the nursing home has there. So that's kind of like in the nutshell what I would tell this guy. I don't know if that helps or not, but that's what I would do.
Of course it does. Thank you so much. Leslie, do you want to speak a little bit more about her mental state regarding to what Dr. Lubner said?
Yeah, so I did put it in the chat, just kind of addressing that, Dr. Lubner. She did have her PHQ and GAD, and that is done on a regular basis. They've always been at 0. So some of that you have to also wonder too, are there any difficulties with reading and writing or other aspects for this person within understanding? So just to be very clear, it was noted that it is obvious she has a significantly lower IQ and ability to function in the world. And again, her daughter, even as a child, was more the adult within the home, even though she did work her entire life in different types of odd jobs. I also do want to note some things that had come up earlier. Some, recommendations might be things like maybe different types of support programming for the daughter. I'm wondering if folks, may have specific support programs that they would want to refer the daughter to for that type of support, just so that she can have a better understanding, because I imagine there might be significant levels of codependency here as well. So just putting it out there, wondering if folks have recommendations.
Right. No, I think that's very, very wise to, work with the family. I want to be a little bit careful about IQ. I mean, she's not vying for Mensa. I mean, that's clear. But people with a low IQ can make their own decisions if they, they can understand what you're telling them, and and explain in reasonable terms. And also, if she's intoxicated when they're evaluating her, then that's not going to go well either. So I would skip the IQ and stick with mini mental status or MCOG or something along those lines. And then you're right, the family could probably benefit from peer support with I don't know if it's called Al-Anon or groups like that that are supportive, because the family is a key aspect of this person's quality of life, safety, and everything else.
Didi.
Yeah, thanks. I hate to disagree, but I'm going to. Al-Anon, I think, would be a disaster for the daughter, because what they would suggest is that she cut off the mother, and that's not going to be helpful for anybody. So if you want to go with a sort of generalized support group that would be free, I would send her to Smart Recovery Friends and Family, if anything. But I would also suggest something like Harm Reduction Works that has a friends and family chapter, or somebody like me that does work with families in a harm reduction sort of frame. And part of what that work is to work with folks around their own anxiety. How do we manage our anxiety around people that we love and their risky behaviors? Because that's my job, if this is my mother. It's not fair for me to tell her she can't drink at 73 years old. And one of the things that I find fascinating, and speaking of IQ, so I agree with that part, Dr. Luckner, is if she's managing to sneak out of a care home, she's got some smarts. I'm impressed. And I'm afraid I'd have to say that to her and say, how are you doing this? How did you come up with this plan? Because that tells me something. It also tells me that the alcohol is important. I mean, has anyone had a conversation about why is she involved in alcohol? What does it do for her? I think that's another piece. And then I've had a client who microdosed alcohol, which I found fascinating. I'd never heard that before. And so she was teaching me, and she would have small amounts through the day, and she had a limit on how much she would have for the day. But that was one of her ways of beginning to manage her alcohol use. And I see this as a medication. And this woman happens to prefer alcohol versus a benzo or something that might be similar. Well, it's legal and she's of legal age. And if the care home is okay with this, and it sounds like she is, then again, my work with the daughter would be around helping the daughter to manage her own anxiety around mom's behaviors and say, this is mom's choice. Yeah. Thanks.
Thank you, Didi. And I was going to ask you if you could repeat or just add to the chat the name of the first organization you talk about. I think you said Sparks, and I was trying to look it up and I didn't find it. Elisa.
Piggybacking off of Dee Dee there, I was wondering the same thing. Like, who has anybody actually spoken to her? Is she open to, and I say therapy, but I mean just having a conversation about what it is that she's getting out of the use, and what are other things that she enjoys doing there at the home? Does she even like being there at the care center?
Yeah.
And if so, what does she like about being there?
Yeah, no, those are good questions. So what I know is that when they have addressed alcohol use with her, obviously for a very long time, they've seen this person for a long period of time. She will repeat and kind of parrot, "I like it, I like it," and that's all. She actually does not have a large ability to answer most questions. Just to note this again. So just trying to emphasize, where her functioning is related to that. She can do manual tasks and repeat those tasks once taught, and she will have some engagement in conversations, but it is very low. And she likes being there because she likes having her own room. So she really appreciates her own room, and she liked also being at the daughter's house for the same reason. So she really hasn't given further large amounts of information related to that. They continue to try. She says that she'll sit with her for about a half hour to 45 minutes on some of her primary care appointments, just trying to be very, slow with her and have open conversations so she doesn't feel rushed, and just trying to be there with her so that she can learn more about her and her interests. So that's just kind of giving you a little bit more related to that.
And anyone else in the group who hasn't spoken yet? I'm sure that some of you have had probably a similar case. Someone who's seeing or supporting someone who uses alcohol. Please unmute yourselves. We want to hear from you.
Yeah. I'll note, I love what Dee Dee had talked about and said as far as the microdosing or, having the nursing home. Some nursing homes do control alcohol with patients that are there, or with people that are there. Some don't. But I'm not sure if this primary care has actually explored that yet at all. So that's I think another great recommendation as well. And I'll also do the smart recovery and all of that as well. If they can, because I have actually seen that be very successful for other patients. They will bring like a glass of wine. So it'll already be poured, and they will bring it out with like every meal. So then too, it's coupled with a meal, which is helpful. And that would significantly help reduce her fall risk throughout the day. Because again, I don't know if she has good information or detail on how much or how she's drinking it. And I will say that as long as she has the alcohol, she does not try to escape. And it is a open nursing home. It's not a locked care facility. So just to note that she's not on a locked floor, so you can easily leave. So she does just leave out a door, but she doesn't tell anybody, right? And unfortunately, as we all know, I've worked in many SNFs, and that's very easy, right? Unless there's a reason to have a bell on your bed or anything else that is not monitored, and nor will they do that because that is not within what she needs for the level of care outside of alcohol. So that's already been asked by the primary carers to try to increase some of that, but that's not what they can provide, just to know.
Dr. Antoine, in regards to the medications that she's currently taking, do you have any observations or suggestions?
Yeah, I mean, actually, a straightforward one, and I'd be curious about others. The thiamine is at a good starting dose for replenishment that could reverse cognitive impairment. You would need a higher dose on that. Some of the protocols we've looked at here, so possibly going up to 300 milligrams a day could be helpful there. More, you have to do IV thiamine to get something more impactful, which might be difficult, but that could be a higher dose there. Obviously, rechecking the lab work for the thyroid to make sure that isn't under treated to see if there's a reversible dementia there as well. A long shot, but again, this goes into the contemplative fashion of where the individual is. Now, naltrexone could be something to limit the alcohol use, but again, that would have to be a choice the individual. But that's what sticks out to me at the beginning. I'm also struck whenever I see all zeros on any screeners, I say maybe we're missing something. So there could be some other behavioral health aspects going on, and yeah, but I think it starts with the conversation with where the person is with the medications.
I love those. I just wrote those down as well. And I do really want to emphasize my suspicion when I heard the case and heard how she responds and answers questions a lot. There may be a significant difficulty with being able to read and write. We actually see that with a significant portion of our population that is being served there. It is not something that is like, oh, I haven't seen that today. It is pretty much almost a daily happening where we have a population that does not read or write. And so I think what's missing might be to encourage their MA or the provider to just have conversations with that rather than screening tools related to that. And I think that might be a better place to start as well, just to throw that out there.
So Leslie, is that you mentioned kind of a rural area in a way in Arizona?
This
Kind of
case is not in
rural?
Arizona. It is
Oh,
a different state. Yeah.
okay. But it's
Yeah.
kind of a small town or rural area.
Somewhat. Yeah. Yep.
Mhm.
Yeah.
Dr.
There was a
Luke?
question about the peer support organizations. I mentioned the Al-Anon. Obviously, there's some concerns there. There's also adult children of alcoholics is one, and then Smart Recovery Family and Friends. And just to clarify with the Al-Anon, I mean, obviously, different groups are going to be different. So it's any sort of peer group, but officially they don't promote cutting off the family member, but they do promote the idea that the family cannot fix the alcoholic. I mean, it's something that they can't just try harder or keep try to keep the alcohol away from them. It's not going to work. So maybe some of that, but I mean, there can be bad groups of anything, bad doctors, bad nurses, bad psychiatrists. I mean, I wouldn't judge the whole entire organization necessarily by that.
Thank you. I will put that on the list as well. I appreciate it.
And Elisa, I'm going to let you do a little summary of the session, and if we can kind of quickly go through again some of the suggestions discussed today for the case. Thank you.
Alrighty. So for this case of this 73-year-old woman who's struggling with some substance use, it sounds like some of those recommendations were first basically checking over all the health, the vitamins, the medications, etc. It was also recommended that the PCP facilitate between the client, the daughter, and the nursing home, respecting both the autonomy and, of course, keeping in mind the safety of that client. Another suggestion was improving environmental controls or seeing what environmental controls or supervision might be considered. Other recommendations included smart recovery for friends and family, as well as harm reduction for families, adult children of alcoholics and Al-Anon as some possible resources for the daughter, and also the possibility of dosing out that alcohol there in that nursing facility. Lastly, some medications that might be helpful in reducing the substance use were also discussed as well.
Thank you, Lisa. And I want to thank all of you for attending today's Behavioral Health Echo. Please take the time to answer that post-session survey, please. And we'll see you next month in the same space. Thank you and have a great rest of your day.